Welcome back. Welcome back. I hope that you all had an opportunity to grab some yummy lunch. Let's get started with our breakout session, Race-Based Trauma and SDOH. Joining us on stage, Dr. Joshua Anthony. Hey, psychiatry resident at Doc Nation. Lauren Powell, VP of U.S. Health Equity and Community Wellness at Takeda Pharmaceuticals. Shanta Chambers. Hopefully I said that. Is it Shantae or Shanta?
Shanta.
There we go. Okay. EVP for Health Equity Initiatives and Community Engagement at Patient Advocate Foundation. Isha Williams. Did I say that correct, Isha? Aisha. Okay, listen, by the end of this, I'm going to get everybody's name correct, okay? Aisha Williams, Head of Culturally Inclusive and Relevant Marketing at Janssen Pharmaceuticals. And Chanel Fowler, Director of U.S. Public Affairs, Immunology and Abiv.
Absolutely.
All right. Hi, everyone. I thought we were going to stop and have a party here for a second. Shout out to the DJ. So my name is Matthew McCurdy. I'm a co-founder of Black Health. I'll be moderating this panel today. Really excited to be here at COCHI, the second equity in IBD. It's been really nice to see the growth here. I was here last year, and it's tremendous to see the growth in year two. So shout out to Melody, the COCHI team, and the COCHI ambassadors. Really excited today to talk through race-based trauma and the impact of race and racism on health outcomes, and to describe the problem a little bit, but more excited to hear about solutions, right, and how we move towards health equity and racial justice. So excited to be joined by our panelists today, but y'all didn't come to hear me speak, so let's dive into it. So the first question is open for everyone, and we'll start at the end with Shanta, so you all have a really fascinating journey that brought you into this health equity, racial justice space. Can you share some details and why the topic we're discussing today is of a particular importance to you?
So thank you so much, Matthew. I'll bring it down. I had to test my mommy voice. So excited to be here. And this topic, so I'm Shanta Chambers, and as they mentioned, I'm Executive Vice President for Health Equity and Community Engagement for Patient Advocate Foundation. I come to this space, number one, as a Black woman. Number two, as a Black woman executive. And number three, as a woman who grew up poor. So all of those things shape my personality, they shape who I am, and they shape my life experiences. And it is because of all of those experiences why this topic of equity is critically important. So I come to you in all of those dimensions. All of those dimensions for me have to show up every single day. And even in many spaces, as the previous panel mentioned, we still have to have some real conversations about race in America. What that really means in the context of healthcare, what that means in terms of access to healthcare, and what that means in terms of adherence to healthcare. We are the richest country in the nation, so the disparities that we talk about and we're going to experience, they should not still be existing. That's why I'm here today. That's why this topic is important, and I believe collectively that we have the solutions, not to disrupt, but just dismantle racism in our country.
Love that. Dismantle, not disrupt. Lauren, please, why is this topic of today of interest to you?
Yeah, thank you so much. Again, my name is Dr. Lauren Powell. I'm VP of U.S. Health Equity and Community Wellness at Takeda Pharmaceuticals. A new role and an exciting way to see health equity moving into the pharma space, which we know is completely appropriate and in some ways overdue. This topic is the reason why I feel like I'm here on Earth. This is my purpose, and I'm a former state health official, so I've worked in a lot of different parts of the healthcare ecosystem. I've seen how racism shows up in a lot of different parts of the healthcare ecosystem, and I happen to think that racism is a public health emergency. It's not just an issue or a crisis or a problem. It is an emergency that requires urgent action and intervention. It requires leadership. It requires us to be serious and honest about the ways that racism continues to exist as a system within this country. And it's what I'm committed to dismantling and undoing for my entire career. So that's why I'm here today, and it's an honor to be with you.
Thank you. And Aisha?
Yes, good afternoon, everyone. I'm Aisha Williams. I'm the head of culturally inclusive and relevant marketing at Janssen Pharmaceutical Company of Johnson & Johnson. And my journey to the health equity space has been an interesting one. I spent the majority of my career working in consumer healthcare, so over-the-counter products that you may buy at the pharmacy to help you stop smoking, to help you with a cold, to help you brush your teeth, with a prior organization. And I did that internationally, including the last 4 years I've spent living abroad across Latin America and Brazil and in Ecuador. And something happens when you uproot your whole life and you go and do something so fundamentally new. So when I was in Latin America, I had a chance to experience diversity and inclusion and equity from an international lens. I was a Black woman in a lot of different places, which was an interesting experience. But also during those 4 years, I had the death of my mother from Alzheimer's disease, and we had a mental health crisis and diagnoses with my son. And so when I came back to the US recently, I really thought about the talent that I have to give, but the legacy that I want to live. And so my decision to come over to healthcare and to this great new role at Janssen is really about me making sure that I can make a difference and use everything in me to make a difference in this health equity space. So it's a true pleasure to be here today.
Yeah, great. I know that Aisha could also do that whole spiel in Spanish, too. And then Chanel, again, we'd love to hear about your journey here, and then why today's topic is of particular importance to you.
Well, thank you for inviting me here, Coach E. My name is Chanel Fowler. I am Director of U.S. Immunology Public Affairs for the AbbVie organization. So in my charge and remit, it's dermatology, gastroenterology, as well as rheumatology. And one of the things that we're starting to notice is that there needs to be greater access to information, to resources, for everyone, but particularly for people of color. And part of the remit of sitting in the middle of the organization is being able to see it from the top, from where we have our patients represented, when we have our advertising, our partners. Equity is a broader topic at AbbVie. It is living from the beginning to the end. It's one thing to have great innovations. It's one thing to have all this great medicine, but if the people who need it don't have access to it, then we have to ask ourselves why. And so part of my journey is to be able to understand where the gaps exist, where our organization can fill in, and how I can partner with other organizations to really right some of the wrongs and deconstruct some of these challenges. And I come to you as a mom, an executive, a wife, and a good old Delta, in case there's some out there in the audience for us.
It's going to be a long afternoon.
Like a good Delta.
All right. And then Josh, same question to you.
Hello, everyone. My name is Dr. Joshua Anthony. I would say that my journey with health equity and race-based trauma began as a medical student at Meharry Medical College. At the time, it was one of 3 historically Black medical schools in the country. So during training, we actually spent a lot of time focused on health equities and focusing on the need for representation and kind of exploring what that meant in providing care to our patients, what that meant in terms of how our patients would show up, whether or not they would show up at all. And so from there, I actually decided to go to business school. I got an MBA in healthcare management because I kind of wanted to explore it a little bit further from a systems perspective. So from there, I founded Doc Nation. The purpose of Doc Nation is actually to increase the accessibility of Black healthcare providers, but actually just Black professionals in general to the Black community and whatnot. Because sometimes it can actually be pretty hard to find people that look for you when you're looking for care and treatment. And we know research has shown that a lot of times, if you're Black, you do receive better care from people that look like you, but also if you're coming from a Black community, you are more likely to look for care from someone that looks like you and also to follow recommendations. So for me, working in psychiatry and mental health, the topic of race-based trauma actually has a huge impact, not only on the mental health of the Black community, but I would say on the mental health of society at large. Sometimes we don't realize it. We think that maybe it's just minoritized communities that are affected by racism, but actually it's everybody. So I'm looking forward to this conversation and seeing where we go from here.
Yeah, wonderful, and really appreciative to share the space with you all today, and to think through, again, how do we get to solutions, how do we get to health equity? And so I know that we're throwing a lot of jargon out here. Oftentimes we, public health officials, professionals rather, can do that. So I would really love to start with the basics, right? What is a health disparity? What is health equity? And so Shanta, can you give us a little bit more information, some definitions on those words, and then we'd love to hear more about how you're working to help us reach health equity.
So absolutely. So when we think about health equity, what we're talking about is that everyone, health equity means everyone. Say that word, everyone.
Everyone.
Now look, I was married to a pastor for 25 years. I know about respond. So we're going to try that one more time. Health equity means everyone.
Everyone.
Thank you. I was going to pass your collection plate. So health equity means that everyone has a fair and just opportunity to attain the highest degree of health possible, based upon what that means for them. So that's the meaning of health equity. Everyone has a fair and just opportunity to attain the highest degree of health available to them. The other word we often commingle with health equity is health disparities. Say that, health disparities.
Health disparities.
Health disparities are the outcomes of inequity, in short, but the definition actually is preventable differences in disease burden and opportunity for experienced by socially disadvantaged populations. Health disparities are the outcomes of inequities that most importantly are experienced by socially disadvantaged populations. I'm using my word choice intentionally. I want to add another word, race. And I make notes.
I like it.
So I love the way that author Michael Brooks, the author of the book, The Race Delusion, defines race. Race is not determined biologically or genetically, but that is actually a social construct. What did I say about disparities? Disparities are preventable differences in disease burdens and outcomes experienced by socially disadvantaged populations. I just said that race is what? A social construct. So when we begin to look at disparities in diseases and outcomes in diseases, and we see oftentimes it is mostly Black and brown communities at the top of these numbers, or morbidity and mortality rates, we have to go upstream and ask ourselves, what are contributing to those factors? One of the things that I always like to say, we talk about the social determinants of health, right? The social determinants of health are going to be those non-clinical factors that impact health, because we must understand that health actually takes place in the community. Medical care takes place within the four walls of the healthcare system. But we often forget that we have to address the education, the economics, the housing situation, the social support networks that are so critically important if we want people to be able to access and adhere to care. And so as we think about health inequities, how they drive health disparities, we have to understand that the underpinning of all of this is race. The social constructs that were erected in our society to advantage some populations and disadvantage others. And so as we talk about this, I think it's critically important, let's call it out. It's a social construct. That is what it is. And as my colleague Daniel Dawes would say, these are the political determinants of health, just as they are the social determinants of health. So even if we look upstream at some of our historical policies, whether they were the Hill-Burton Act that looked at where hospitals and healthcare were actually erected, or if it was the Fair Housing Act that actually was responsible for the establishment of multi-unit houses, AKA projects, then we begin to understand what we see playing out in our healthcare systems and the healthcare outcomes for persons of color. It was all a part of the systemic design that drives racism in our country.
Yeah, beautiful response. Thank you so much for that. And building on that, Lauren, I want to come to you now. Specifically, we think about race as a construct, and often we see race as the exposure. But what the public health field is what we're really trying to do as far as a racial justice movement is that exposure is really racism. So can you talk a bit more about how racism has an impact on health outcomes, and then again strategies that you see to mitigate that impact?
It's a great question and dissertation level worthy. I don't have enough time to go into that level of detail, but
36 minutes.
Thank you. I'll use every single minute. Racism is detrimental to the health outcomes and the wellness of Black and brown people in this country. As I said previously, I firmly believe it's not just an issue, it's not just a crisis, it is in fact an emergency. If we were to look at how many deaths per year are actually accumulated in excess for Black and brown people as compared to white people, there's actually the American Medical Association published on this. The number is, I think, 74,000 deaths in excess per year in Black people versus white people. Now, for any other crisis of that magnitude, for any other amount of loss of that magnitude, it would be declared an emergency. And yet, the racism in the fact that we have not declared racism as something of urgency that requires a whole response from society, especially from the healthcare industry, really says a lot. We know that racism is a structure and it's a system. There's individual levels of racism, which are much more insidious and kind of like one-on-one interactions, but there's also structural and systemic racism. That is racism embedded in the ways that systems just operate. So it's just a part of how the systems work. I would say that there are lots of ways that racism operates very freely within the healthcare ecosystem. From the ways that we don't take the time to fully diagnose and even listen to Black and brown patients. We could look at maternal mortality outcomes for that. From the ways that Black and brown people are sometimes subject to much more invasive procedures. We could look at diabetes outcomes and amputation for that. To the ways that mortality and life expectancy are so much shorter for Black and brown people in this country, not because they're inadequate in any way. Let me repeat that, not because they're inadequate in any way, but because we are within a system that is socially constructed to not work in our favor. And because we are discriminated against at every given turn, from housing discrimination in the way that redlining literally created neighborhoods that are without resource, to the ways food insecurity has created an entire foundation for people to not be able to even access nutritious food, to the lack of transportation that's even available for people who want to actually receive care and access care, to not even be able to have the option to do so. And there are so many ways, like I said, I won't go on for 36 minutes, but the bottom line is racism is built into this society. It is built into every single part of the healthcare ecosystem. And we have research that shows us that outside of even that, merely the anticipation of a racist encounter has health implications for us. So whether or not I'm living in a redlined neighborhood, which still exists today, let's be clear about that, whether or not I'm experiencing food insecurity, whether or not I have my own transportation, I'm a Black woman in America. I face and deal with racism every single day. Merely then the anticipation of a racist encounter does things physiologically to my body, increases chronic stress, and has an impact on my life over the entire lifetime, over my entire life. So this is not just in kind of in the moment, a discrete exposure. This is a chronic exposure. And we have research that shows us what that does to children over the lifetime as they grow up, as they become adults, as they continue to navigate this society. Again, I say racism is not a crisis or an issue, it is an emergency.
Yeah, I really appreciate that framing as racism as an emergency. When we think about the response that happened to the COVID pandemic, for example, and that was an emergency that we had, and we think about the amount of money, funding, attention that was given to that, if we were to direct that same amount of resources towards the impact of racism, what kind of world could we live in? So I really appreciate that framing, Lauren. Thank you. And then coming to you, Josh. So we've thrown around this word, race-based trauma. I know that you are really thinking a lot about individual, but also community mental health. So we'd love to hear, one, a definition of race-based trauma, then to think about more broadly how it has an impact on community-level mental health.
Yeah, definitely. So race-based trauma is the ongoing result of racial bias, racism, and discrimination that we experience in person every day and that we see in the media. A lot of times, the effect that has on people is very similar to the effects that we see in individuals that suffer with PTSD. So that goes to say is what's alluded to just a moment ago, that a lot of individuals in Black and brown communities are actually walking around with chronic PTSD symptoms, and that has a huge effect on your overall health. The number one cause of race-based trauma is racial discrimination. According to Pew Research Center, they released a report where they said 76% of their respondents, their Black respondents, admitted to personally experiencing some form of racial discrimination in their life. So if you're Black or brown, if you're Black or brown, there's a strong possibility that this is something that you've experienced at some point in your life. A lot of times, these experiences start during childhood. One of the things that we talk a lot about in mental health and psychiatry are ACEs, or adverse childhood experiences or events. And these are experiences that are very closely related to social determinants of health. But one of those things is like exposure to racism, also growing up in poverty. A lot of these things, even though they're not directly caused by race, there's a huge association with race. So if you look at which group of people in the United States are the poorest, then or which group of people in the United States have the least access, you might start to see a pattern. And so, as those things start happening during childhood, it creates this direct effect to the health outcomes that we see in Black and brown people as adults. So, like we've been saying up here so far, racism, racial trauma is a very huge deal. It's an emergency, and it's something that we need to take very seriously if we are actually concerned about addressing health problems in this country.
Yeah, no, I think that's a really good point. And when we think about ACEs, it's disheartening to think about the impact racism has on kids, right? And we tend to think of this as a problem that affects adults. If I'm going to the physician or if I'm going to the doctor's office, they may not see me or give me proper treatment. But what we're actually seeing is that literally from the moment someone is born, or even before they're born, from when they're in the womb, it's having an impact on our Black and brown children. And so, Aisha, I'm going to come to you next. When we think about racism, we've been talking a lot about medical mistrust. We've been talking a lot about how we have difficulties interacting with the healthcare system. So I really would love to hear you say a little bit about, as a marketing executive, how do you think about building that trust? How can we reinsert, trust within our communities in the healthcare system?
Thank you for the question. You talk about build trust. I think build is a good word because trust requires a foundation. And I think the foundation of trust is listening. You mentioned the jargon. We talk about insight and marketing. And we talk about asking why, that constant sense of why, but tell me more, but tell me why, to get to the true root of the issue so that we can help. And so at Janssen, part of that is coming to events like Coachy and listening to the patients. And just this morning, we can take away more insight than we can get 6 months at the office. So it's a lot of working with our patient communities, working with our advocate organizations, working with the physicians who work with patients day in and day out to gain an understanding so that when we're putting together programs, our trials, are thinking of solutions to help, that they're truly informed by the people who need our help. So I think that listening is a key piece of it. The other piece is working together with others. We don't engender trust as a pharmaceutical industry in communities of color. I think we're all working on it. It is a house that must be built, but working through community partners. So again, the work that we do to work with advocate organizations, to work through organizations that have a pulse and already a credibility in the community, is how we're going to inch our way into being partners. Because the goal is not that as organizations we're trusted. The goal is that we help. And so whoever are the conduits for us to do that, that is our approach to make sure that we are reaching communities. And I believe that as communities of color can see our support through organizations who understand them, like Coachy, then it can be a side product that they begin to trust us a bit. But the most important thing is that we support them.
Yeah, and I think that's really important. It's a pathway, it's a road that we have to travel, and not necessarily a destination, right? It's continuous work to build that trust. Chanel, coming to you now, I'm thinking, again, about this opportunity that we have to get towards health equity. I know that you're particularly thinking about health communications. So, around health communications, disease education, how can we break barriers when it comes to racial health disparities?
I will tell you, disease education is so critical to patients, and it's because you want to co-author the journey with your physicians. You don't want to just say yes to everything. One of the things that we love is the why, and really trying to empower patients to understand the treatment options to come into the physician's office completely whole. We all know that Dr. Google exists, right? But there are credible areas and credible resources, whether it is a patient advocacy organization like Coachy, whether there is, Coachy, I always say that wrong, Coachy, or there is another organization that is affording you that type of access. Community-based organizations have worked really hard, and those are your National Urban Leagues and your NAACPs, are worked really hard in our communities for decades, and they have established trust. And leveraging those resources, leveraging organizations of color to be able to identify those physicians. So, for example, in our when you look at dermatology, I was talking with someone today, and they were looking for a Black dermatologist, and I said, try Skin of Color, the Skin of Color Society. The doctors will list out all the doctors of color around dermatology in your area. And then from there, look at the additional resources. How do you approach that appointment before you go in? List out all your concerns. We have at AbbVie, a lot of our disease education is around co-authoring that journey with the patient. How do I talk to my doctor? How do I talk to him about or her about everything? Maybe I walked into there and I was speaking more about, I think I'm in a flare, but all of a sudden I have, a lot of itching. What does that mean? But I'm disconnecting those two because I'm not looking at this entire moment as a moment to have them co-author my plan. So when we look at education, it's important for the patients to really, really believe in the why, not blindly accept whatever the physician may do. And we are big in the African diaspora of the word of mouth. We find everything word of mouth. We find our hairstylist word of mouth. We find, well, where you get that from? Word of mouth. Well, find your physicians, word of mouth. Recently, I had an implant placed in my tooth. I had a root canal that went bad, and then they had to do an implant. Now, I was on Instagram, probably still under medications, talking to people on Instagram, which was ridiculous. And my friends were trying to take the phone. But when I woke up that morning, I had all these DMs of saying like, Chanel, who's your oral surgeon? Where'd you go? Where'd you go? Where'd you go? Where'd you go? Not one, not two, but 6 people asked me who was my oral surgeon because they had been looking for one. They were putting off the procedure, but they just wanted to find somebody they can trust. As soon as I said this is where it was, they trusted me because I was there. We have to leverage all our points of influence, but we also have to leverage the advocacy of ourself. And being able to walk into the doctor's office and know that the most important person in this conversation is you. And if you don't feel connected, you don't feel heard, if you don't feel valued and seen in these moments, then you need to tap out. You need to tap out and be like, okay, this was great, thank you, and then identify a second physician. The one thing that has happened because of COVID, that was the one shining blessing of COVID, was there was a increase in teledocs. And that affords you an opportunity to visit a physician who may not be in your area, but has access, you have your medical records, have access to them, and have that appointment with that physician. These are things that we have to look at collectively, not as I just walk into the doctor's office, I got a pamphlet, and I walk out. And we cannot look at it like this. And the one thing I want to say, brother, on that mental health, I don't think we talk about that a lot around education and about how disease has impacted us from the moment we wake up and to the moment you go to bed. And having that burden sit in your space every day, 24 hours a day, every month, 360, what does that do to your system? We just don't, oh no, give it up because we just
clap
don't.
louder.
You can clap. We don't talk about that. And that is real around education. Yeah, I can treat here, but I also need to treat here and here too.
Yeah, that's a really great point. When we think about mental health and we think about the way, again, and we've alluded to this, that racism has an impact on us physically, has an impact on our mental, has an impact on our communities. It's really important to name and call out all of the ways that racism is insidious within our communities and within our lives. But I would really love to talk about some solutions. And so, I'm gonna just go back down the line and really start with Shanta. I was thinking about the COVID pandemic, right? And, early on in the pandemic, it was, oh, Black people can't get this. And then shortly soon, it was like, oh, Black people are the ones dying the most. But, as we've shifted to where we are now in the pandemic, I'm sure that, over the last 2.5, 3 years, there have been some epiphanies, some aha moments in your work. I was like, oh, we can actually do this better. So we'd love to hear about, how you're thinking, differently about your work, given the context that we are now in, and, the strategies, again, that you really find successful for getting us towards racial health equity.
So Patient Advocate Foundation as an organization has really been at the intersection of healthcare and access and affordability. Because one of the things that we don't talk about is the number of underrepresented minority, Black and brown individuals that are uninsured or underinsured. We don't talk about that. So if we think about if you're uninsured, you're probably not going to access health care. So all of this wonderful innovation that we're talking about and we're bringing forth, because people don't even have the financial means to access it, then we end up with late-stage diagnosis, as one of the panelists pointed out earlier. And then if you are diagnosed with a chronic condition and you're no longer able to work, then you have these cost of living expenses that you're now dealing with. Talk about stressors, right? So you have someone who has now been diagnosed with a chronic or complex health condition. They are uninsured. They now may not be able to work, or their work may be reduced. They're thinking about all of the things like housing and food and their family and their children. They're thinking about all these things that have absolutely nothing to do with their health care, actually, but are so fundamentally important for them to actually be able to access. So Patient Advocate Foundation as an organization said, wait a minute, as we think about the need to help people navigate medically, we need to have resources to help people navigate some of these social conditions. So as an organization, we've been working very closely with community-based organizations to understand what are your populations dealing with as it relates to being uninsured. Do they know how to access insurance? Do they know what it means when we talk about copay deductibles? If your patients are insured, do they know that they can have the right to an appeal if a course of care has been denied? So many things that they don't know, but then no one is taking the time to help them navigate through those kinds of things. And so as an organization, we've been taking it to the community. We always build programs for patients, oftentimes not with patients, but let's be honest, we always say, let's build it and they will come. Well, doggone it, patients have told us that they are tired of coming. And so we know we need to go to where people are. We need to meet people at their point of need. And so we as an organization have really taken up this philosophy around equity that guides who we serve, how we reach them, and what we do. We're asking ourselves those hard questions. We collect all this data, and where data is telling us that we're having disparities in our services. So we looked at our data, and we forced ourselves to erect new programs like copay assistant programs that help people offset some of those pharmacologic costs, financial assistance programs that provide small grants to individuals to help them pay for rent and utilities and all of the, and transportation and childcare, all of these other things that we don't always think about. But more importantly, when people call us, we're not saying, hey, here's a list of all the people that you can call. We're right along there with them, making those calls, making those applications, because we make the assumption that people understand. And we make the assumption that everyone knows how to navigate this thing called healthcare. And the complexity of the healthcare ecosystem, I say it's like Prego spaghetti sauce. We know it's in there somewhere, but oftentimes people don't know how. So our mantra has been, we're going to stop waiting for people to learn how, and we're going to take these resources to where they are.
Yeah. And I love that distinction of with rather than for, right? We have to work with communities. We have to build with communities because if we do things for communities, they often may not work, don't land correctly. So then coming back down the line, Lauren, what are you really working on, seeing that's working well in communities?
Yeah, it's a great question. So Takeda, we're early in our health equity journey, and my role is new, but we've had some really great strides that we've made in the past year and a half. We've created an entire health equity framework that is rooted in guiding principles, one of them being anti-racism and anti-oppression, and really being very thoughtful and cognizant of the ways that we have internal work to do and external impact to make, right? I think so very often, healthcare institutions just want to jump to external impact, right? We're less likely to want to think about the ways that internally we have some work to do too. So we've actually started, much like we did in this conversation, with just a definition of health equity. I've been in so many different rooms with very brilliant healthcare leaders and practitioners in healthcare and providers of all different levels who have never heard what health equity is. And so if I'm going to ask you to operationalize that in your daily work and activities in your role, I have to help you understand what it is first. So we've started there. We're working really hard on learning and development so that when we actually go to start making some of this impact, we're doing it not just through a lane of good intentions, but we're actually knowledgeable about what it means to build an authentic relationship, what it means to be a partner and not a sponsor, what it means to actually advance health equity and not just talk about it. So we have activities to go to, like, undergird our words. We're not just talking about, we're actually doing it. We've had the pleasure of launching 2 major multi-year health equity partnerships, which we're really excited about. One is with an HBCU, Xavier University, Louisiana, who has a Center for Health Equity and really is very deeply trusted in the Louisiana community, in the Deep South altogether. But really, I appreciate so many comments about trust and recognizing the ways that we need to work with organizations and with leaders who are already trusted, and to expect that communities who have never had a reason to trust us before would just flip a switch and just trust us all of a sudden because we say so, is also rooted in racism, right? So thinking about how can we create an organization that is trustworthy. We are worthy of your trust. And so that's really how we are focusing our efforts, both internally, thinking about everything from market access to our public affairs team and the policies that we support, the ways that we can advocate for health equity through policies as well, the ways that we are a convener and collaborator across the entire healthcare ecosystem, and the ways ultimately that we can really advance health equity beyond just diversifying clinical trials. Right? I think that's where we tend to just go very easily. That's one step, but there's so many other things that we need to do, and so we're excited to be embarking upon that journey.
Yeah, there were some bars in there, and I really appreciate, again, the notion that it's on the responsibility of the organizations to become trustworthy and not responsibility of the community to just give trust, right? And I think that's a really important distinction, so thank you for that. Aisha, coming to you again, what are you seeing that's working? What is your organization working on in the health equity and racial justice space?
Absolutely. I like to pick up on that notion of it starts on the inside, because there is an inside and outside approach that we're taking at Johnson & Johnson. My role, like Lauren's, is new. I think that one of the ahas of the last few years is the reveal of the big secret. There's some aha across the industry that all of these health equities inequities exist, and I think I've been surprised by the surprise. But we're taking a lot of action, and so one of the things I think is really important now that the conversation is out there is helping to educate step by step the people inside of organizations as well. So in my role, it's all about helping to educate our teams on how to go about health equity work. And we focus on 3 things primarily. We focus on insight. We have to understand, regardless of which condition it is, how that affects emotionally, through the medicine, physically, how that affects the different communities that we serve. And we always say, we talk about the patient. There is no patient. There's the rich diversity of patients that we serve, and so we're changing that conversation by not only bringing in insights, not only going out to speak with patient communities, but also making it a fundamental part of what we do. We will no longer do research that's not representative. We have an effort to make sure our clinical trials are more representative. We don't have time in this space to keep taking our time, so there's a level of commitment that we will do things differently. So insight is one. Know-how. This is a sensitive space, health equity. Racism is a sensitive space. And so we have conversations, and we have training, and we have engagements with our whole commercial organization to make it okay to talk about this stuff. When you come into a meeting, people say, I don't know if I'm using the right word. That right there shuts down so much conversation that could have. So we're making it okay to just talk about it, even if we don't get it all right. If we have the good intent, then we can move forward and sit down and figure out what to do. So there's a lot of training in that space. And then last but not least, measurement. When we go out and say we're doing this, we're committing that, is it working? Is it making a difference? And so we have to have infrastructure in place that we can understand how our work is landing with communities of color, quantitatively, quantitatively, and therefore we can then make adjustments. So that's a big part of my role in culturally inclusive and relevant marketing on the inside. But on the outside, I'm very proud of our Johnson & Johnson, our Race to Health Equity. We've committed $100 million over the next 5 years, just as a start, to help make sure that we're driving health equity work. And so I mentioned earlier that's in 3 parts. It's making sure we diversify our workforce. We have to have the people in the room who've had the experience. We have a healthier communities pillar. We have to make sure that our care is culturally competent in connection with the community. And lastly, we ally with organizations like COCHI because we have to work through those organizations. So internally, externally, we're trying to attack it from all angles because now that we have the attention, we have to grab this moment and juice it for all that it's worth to drive change in our communities.
Yeah, I appreciate the comprehensive strategy, but also the urgency that you bring to the issue. I think it's warranted and needed. Chanel, same question to you. You know, an aha moment that you've had, and then subsequently the work that you're doing within your organization towards racial health equity.
Yeah, I would think the biggest aha moment is very similar to everyone that has had here, is when people say, "Did this exist? I never knew." And I think it was a little bit of, for me personally, a moment to step back and understand how deep this construct of race is in our country as a whole. And being able to step back and say, okay, listen, we can have the greatest disease education programs, we can have the greatest drug in the world, but if a patient doesn't see themselves represented in our marketing, in the way they approach our disease education, if we're not speaking in the language, using those trusted voices, then we're talking at them, not with them. And we want to co-author this journey with our patients at AbbVie, which is why we're here at this organization today. At COCHI, we want to co-author. Tell us where the gap is. We can research for days, but when I talk with a patient and I'm hearing the same conversation around access, around not having the right doctor, around not having the right resources, where there's a solve for us to jump into. And one of the things that we're doing through our partnerships is really working with already existing trusted organizations who have part of their internal pillars externally is really about equity and about what that means. And it is not, I always tell our team, because immediately, if you know anything about business, you put out resources and you want an ROI tomorrow. And I say, this is the long game. It took us X amount of generations to get here. It is not going to, we're not going to dismantle in 24 hours or in 1 year. So it is the constant drumbeat. It is the constant ensuring that our resources are aligned, and it's being open to feedback. And at AbbVie, we're very open to feedback. And we're trying to work with organizations that can help us be a better partner to the communities as a whole. Everyone is trying, not all are getting it right, but we want you to be honest with us when we're not, so that we can take that feedback back to our organizations.
Absolutely. Same question to you, Josh.
Definitely. I'm really excited about what we're doing at Dot Nation. Two of our goals is to kind of hit the pipeline of providers, physicians at the beginning of the pipeline and also at the end. So to give an example of myself, the first time that I saw a Black physician in person was actually when I got to medical school. So my entire life,
Wow.
I had never seen a Black physician. So we believe very greatly in the need for increased representation for children, for adolescents, because in general, the number of Black male physicians hasn't significantly increased since like the 1970s, I don't think. And so one of our goals is to really increase points of contact for children, for adolescents with Black physicians, with Black healthcare providers. And we are really trying to double down on encouraging them to enter careers into healthcare, specifically in the mental health arena. That's the new old frontier, something that we need to pay a lot of attention to. And then at the end of the pipeline, for the physicians that we do have, physicians of color, we're working to educate them on how to better advocate for patients and also providing support services for them, because a lot of times, as we go through our professional journey, it doesn't matter if it's within healthcare or another profession. A lot of times by the time we finish the training process, we're completely burnt out, probably don't want to have anything to do with the profession anymore. And that's especially true for Black and brown physicians. A lot of them experience microaggressions during training, overt racism. So, racism isn't just a problem that happens at one level, it's, across the board. And the same way racism can make patients kind of disengage and withdraw from the healthcare system, it can actually make Black and brown doctors do the same thing, not want to be involved, kind of leave the academic spaces, kind of leave the hospitals. And so when our patients do come to the hospitals, they're not seeing, people that look like them. And when they do, and this has happened to me a lot of times, they are very surprised. So we want to increase support services for our providers as well, so they have the energy, so that they have the drive, they have the motivation to actually be present in those spaces and to provide the care that our community deserves.
Yeah, absolutely. I think on this journey to health equity, our healthcare staff, our healthcare personnel are going to be tremendously important in helping us reach there. So we're closing in on time. I just want to thank you all for the tremendous value, education, knowledge that you've brought today. And then we'll just spend the last 2 minutes or so. We'd love to end the panel on, what's bringing you joy right now in this moment. We'd love to end on a really happy note. For me, it's been, I'll take the easy one, being on this panel, really learning and being in this space with you all. And then so we'll start with Josh and work down. But again, what's just bringing you joy? What's making you happy for the future of our communities?
For me, it's events like this. So I was at the Equity and IBD conference last year in DC, and to see how it's grown, to see you all here, gives me a lot of encouragement, a lot of hope for the future. Shout out to Mel for putting in the work, and also for being open to just working with different people. We actually met via social media during the pandemic. And so as bad as the pandemic was, it did increase a lot of people's awareness about the different issues that have been going on for quite a while in the community. And it did increase opportunities for interaction. So I'm thankful to be here and thankful to see the growth that's happened.
Chanel.
I think what's bringing me joy in this moment is all of you. I will break down in tears if I say any more. When I walked in and heard the DJ, when I walked in, I saw people that look like me, that sound like me, that we can relate. I don't think people understand when you, especially if you work in corporate America, when 96% of everyone looks nothing like you, that when you come to spaces like this and it's like-minded, smart, gifted, Black and brown people together trying to solve problems that have impacted our communities that we didn't create, but we are doing our best, because to whom much is given, much is expected, is what's bringing me joy right now.
Awesome. Aisha.
I would say that part. I think that the courage, the resiliency, and the swag in this room, we have a long way to go. There's a lot to unravel. But we have that on the inside, and as long as we don't let anybody snuff that out and keep bringing that in our awesomeness, I have hope that things will change, because we're going to shine and make sure that people pay attention.
Awesome. Lauren.
I think the DJ's playlist is bringing me joy. I appreciate that Mary J. Blige said. Thank you for that. I needed it. And I just second everything that's already been said. I've been in a lot of places this week, and this is one where I just walked in and immediately felt the joy. So thank you for being here. Thank you for having us. And thank you for bringing me joy.
All of that. And thank all of you for being bold and provocative, because it takes boldness to come and share your story. But more importantly, it takes being provocative to say, you're not going to just tell me how you're going to deliver care to me. We're going to talk collectively of how we're going to pursue our care together. Don't lose that, because finally, collectively and together, we can put patients at the heart of healthcare.
And we'll end there. Thank you all.